And thanks, Kevin. I really appreciate the opportunity and the invite to talk to your group. I really love what you're doing and wish I could be there in person, but the time restraints limit my ability to travel as much as I'd like to. I'm hoping to accomplish a couple things tonight. One, just to give a little bit of overview. We only have about 12, 14, 15 minutes to go through some ideas, but at least give you an overview of some of the work we've been doing at Medstar Health, the teams that I've been very fortunate to work with. For those that don't know or have a background in Medstar Health, we are the largest integrated health system in the Mid-Atlantic area. We have 10 hospitals, including Georgetown University Hospital, Washington Hospital Center, the National Rehab Hospital, and then 7 other hospitals throughout Maryland. But I think we've been doing what's been very impressive to me, a very concerted roll around population health and out of hospital health, and have now roughly around 260 patient care um, facilities throughout the Maryland and DC area. And so I think I've been impressed with the strategic intent of where MedStar is going. Today, I just want to share with you some of the thoughts that we've been working on at MedStar, and hopefully some of those will resonate with you as we go through this discussion. I always like to start with this saying. I think it really sums up the challenges that all of us in quality and safety are facing today. And it's a quote going back a number of years, but I think it's very applicable to today. Medicine used to be simple, ineffective, and relatively safe. Now it is complex, effective, and potentially dangerous. All of us know we are doing some tremendous things in healthcare. We are curing cancers we never thought curable. We are treating diseases like congestive heart failure and diabetes in ways we never thought possible. Patients are living longer, and yet it hasn't come with some risk in the infrastructure and some of the basic, I would say, non-technical skills that have contributed to that. We all know the Institute of Medicine report. We know John James's updated acknowledgement and research using the global trigger tool to put estimates between 200 and 400,000 patients a year. So preventable harm deaths. So we know the challenges, despite the fact that we're doing some amazing things in healthcare. When we looked at what we were trying to accomplish at MedStar, when I went there, we set our goal around 5 basic core themes, which I think are critical to a mission of patient safety. The first is process design. We really felt we had to embrace evidence-based care. This isn't rocket science. People across the country understand this, whether it was bundles, evidence-based medicine around central lines, ventilator-assisted pneumonias. We had to understand, and we had to standardize those processes across our system. We also had to embrace things like clinical decision support tools, which allow our care teams to just do the work that they're trying to do and do it even better using these assist devices. But on top of that, we felt we had to adopt what's referred to as a reliability culture. We trained up at MedStar over 27,000 people on high reliability science. Everybody, I don't care if you were a chair of a department or you were a patient transporter or you park cars in our valet parking, you had to go through reliability science training, and it really elevated our culture. Board members would sit with dietitians and nurses and really understand the tools and techniques and behaviors that were so important in establishing this high reliability culture across our system. And we went out and used Healthcare Performance Improvement, HPI, which was a great partner with us as we launched that. But on top of that, then we said, you know what, reliability science is really important, and there's tools and techniques we could adopt that other high-risk industries have learned to be effective. But we had to get into a model that we said we got to quit blaming people. We got to quit saying that if we fire a nurse or get rid of a pharmacist after an error occurred, we'll fix the problem. And Reason said it so well, is that we can't fix the human condition, but we must fix the conditions under which humans work. And that's been a big focus of ours at Medstar. I'm very blessed to have 22 human factors experts in our National Center for Human Factors Engineering. Many of you may have had the chance to hear Terry Fairbanks, who leads that center, talk at national meetings across the country. Terry works very close, his team of human factors engineers, with my team and our innovations team and our research team in tackling problems. So we put that human factors expertise on top of our event reviews and both on the occurrence reporting side, so to understand from near misses and unsafe conditions how we could put systems and process changes in place, but also from our adverse events. And then the fourth layer on top of it was truly the partnership with our patients and families. I've learned through the years that if we didn't bring the patient voice into our risk management conversations, into our quality and safety committees, we were missing a good part of the story. We were missing people who could give valuable contributions and make our programs safer and higher quality. So we have not only a national or a group of people who work at the system level with us, but we've also established local patient and family advisory councils for quality and safety. And these aren't, community people who sit and decide what colors the walls should be painted. They're not people who help us pick out what should be served in the cafeteria. They work on hard core quality and safety projects, falls, delirium, things like that. And they have truly made our system safer. And then finally, the overarching umbrella is transparency. It's transparency around our outcomes, whether they're good or not so good. We need to share it. We need to learn from it. It's outcomes around informed consent, or transparency around informed consent and shared decision making. And then it's around transparency around adverse events. How are we communicating with patients and families and being honest? And we're been blessed to be part of a national initiative called the Candor Program, which is communication and optimal resolution, which is driven by the AHRQ and a number of other leading organizations. And so that it's really what we define as our road to success from a patient safety standpoint. I want to get a little bit, while our time's limited, I want to talk a little bit more about human factors. And I love showing this slide to show the thoughts that we are all humans. I don't care how smart we think we are, we will make mistakes. I make 10 to 15 mistakes a day. This is a picture of two cars driving down the street with a gas hose hanging out the side of their gas tank. And I will guarantee you, they didn't go to the gas station that morning thinking that they were going to pimp the owner of the gas station. They made a human error. And I will tell you, if you Google gas hoses out of gas tanks, you will find a website that's got hundreds of pictures of cars, including police cars, driving down the street with gas hoses hanging out of the car. So until we realize we are humans and we need to embrace human factors and high reliability tools like checklists and prompts, we will continue to make the mistakes that we have over the past number of years. And again, I refer to Reason's comment, which I think is so fitting for healthcare today, and what other high reliability or high risk industries have realized is that we cannot continue to tell people to pay more attention, be more careful, get smarter. We need to look at how can I, in my role, and others in similar roles, put processes and systems in place that allow my caregivers to optimize the care that they give, to provide them with all the tools and techniques to do their job as effectively as they can without these traps and things that happen to all of us. Transparency, you heard me talk about, I think is a critical part of our role at Medstar. How are we, embracing reporting? We put a system-wide occurrence reporting system in place. We now have close to 80,000 occurrence reports over the last 2 years of near misses and unsafe conditions. And how are we learning from those? How are we triaging the most common events and really looking at them from a system and process change versus a human change? How are we being transparent in outcomes and sharing our outcomes? I think people understand this, and it's a key part of any safety culture. And then the transparency and communications around informed consent and shared decision making, and especially disclosure after harm. Bob Galbraith, the past chair of the National Board of Medical Examiners Center for Innovation, said it so well, is that if we are not open and honest with our medical errors, we will never learn how to put processes and systems in place to change them and to make the system safer. We'll see the same errors occur over and over. And then I talked about our patient and family advisory console. Here's our system console. I was able to reach out to a number of people I've known through the years and friends, and we get together on a regular basis. We meet quarterly, we exchange emails regularly. These people help us around high reliability, they help us around our patient and family consoles in the community. They really are my springboard for understanding and validating work that we're doing and making sure that they agree we and Medstar are on the right track for where we're going in our mission. And then finally, I just wanted to touch on, was referred to a little bit at the beginning by Kevin. One of the things I'm very proud of, and we're now going into our 12th year next year, is our model of educating the young. How do we get the next generation to understand the importance of patient safety, associate safety, and high quality? My generation, when I went through medical school and residency, we never were taught about these types of skills. So, how are we making sure the next generation, similar to what aviation and other industries have done, are bringing the next generation up with all the tools, techniques, and skills to really be high quality, low risk caregivers as we continue to work on our current state? And so we do now meetings, we do these patient safety, what we call summer camps, where we bring close to 100 medical students and about 70 graduate medical residents out to Telluride, Colorado, to Turf Valley, Maryland, and Napa, California, and immerse them in 1 week patient safety education. And it really, is in my mind one of the most effective ways to try to move our agenda and make care safer in the future. So I will stop there, and I really appreciate, Kevin, the time to share thoughts in a quick manner and touch on some of the key areas that we're working on at Medstar, and hopefully it was of value and resonated with the people participating tonight.